have the primary care systems, we call them health centers. They are all owned and financed and managed by communes. And then we have the secondary care, which is delivered by 20 central hospitals, again owned and financed by counties. And then the tertiary care is delivered by 5 university hospitals. Every Finn has a unique personal identification code, which covers everything, from taxation to court, to healthcare, to social welfare. I can trace all the results, for instance, in aortic surgery from 50 years. It also enables us to bundle cost over time so that we know what it takes to treat bronchial asthma in Finland at the individual level. Naturally, it's also risk analysis can be done so that we can risk stratify the patients, and we can see that there are people with a welfare risk which is down to 100 euros per year, and then another group where the average cost is more than 100,000 per year. Also, we have Health Portal, which is created by Finnish Medical Society, Duodecim, which gives updated information from all the care possibilities. 50 million visits on that side per year. The same information is dealt with in Health Library, which is available through all Finns over internet. So it means also that it reduces the information asymmetry between patient and her physician. So when the patient comes to see or contacts over internet the physician, they already speak about the same level. We use digitalized lifelong medical records. So it's more than 98% digitalized already today. So the same information flows forth and back between the primary health care and the hospitals. Practically all social care is also administered, financed, and also quite often delivered by the municipalities. So that again, they are under the same hub. All man-force is salaried, no other contracts, no self-paying patients in any public hospitals. And I think that that's also something which makes the managing of this kind of business easier. Now we jump over to the problems. Inequity is one of the big problems in Finnish healthcare. One is naturally cost escalation. It still is clearly more rapid than the growth of gross domestic production. We have several overlapping services. We speak about tellers, silos, repeated encounters, double examinations in a country where these all could be avoided. And the services also are fragmented. The idea that we defined health as an ability to adapt and self-manage, as you have taught us Finns to think, I think that it's a very important thing. We are working under one budget, and that is set according to the estimated needs of the target population. And we are trying to balance the marginal cost effectiveness across all active care. And here are the asthma program. This is really a sample of integrated care, dating back 30 years, as you see. And what is here very specific is that this is an economic chart which also shows that the productivity losses can be taken into account. And this green area shows you what is then replacing, what is the success story. This is medication. From 1987, the number of asthma patients has tripled. The costs have not tripled. And you see also how little hospitalization costs this small blue area here. It used to be high, but now it's very rare to see any single patient in hospital due to bronchial asthma. That was total cost at the national level. And these are the individual costs at the patient level. And again, we see that the direct cost of medication, mostly from medication, are here, but the productivity loss, which means sick leaves, early retirement because of disease, etc., is down. They are still in the workforce. And I think that that's a beautiful picture about what can be achieved by judicious integration of care. But how this was done? We have to target on prevention. Ban smoking, take antigen and environment into account. The second thing is that we have to reach early diagnosis and then start effective medical therapy. Educate, shift responsibilities smoothly between professional groups. Deploy virtual health examination where the doctor is able to see any single patient with wrong or deficient medication. Adapt care processes to local factors. I think it's very important that all this kind of improvement is done on a local level, not from the governmental level. Mobilize lay interest groups for your support. They have tremendous power and they're willing to help you. Keep track over time. Prevent sliding back. If you get something done, keep it there. Don't let it slip back. And also, be proud, be loud. If you get something, okay, come over to England and be proud about that. I end this presentation showing that Finland is still best value for money, but I don't even show where the United Kingdom is. Okay? And then my concluding words are that I think that integration means commitment to work together over years and decades. Integration is the mainstream, and managed competition provides marginal aid in selected situations, but only in selected situations. And we'll see this kind of development putting together all the post-industrial countries because we are all running out of money. And this is not a strategy. This is a very deep cultural change. Thank you.
Thank you.